This is a very classic image that is in any talk about HRS. It's from the 1970s, Dr. Epstein up at Beth Israel in Boston, where I did my residency training. It is thrown down our throats there, and we will explain the meaning of this angiogram later. So my learning objectives today, I have to admit to Dr. Fauci, when I was a fellow in 2019 and watching one of your grand rounds, just going over the virology of SARS-CoV-2, I was really taken aback by your use of bold fonts with Arial, black and red bolding. And I stole that, and I never thought I'd have to give you a lecture, so I apologize. But thank you for the inspiration. So what are we going to talk about today? You know, obviously, you can't say AKI and cirrhosis and not talk about HRS. But before we get into HRS, I want to talk about the mortality associated with AKI in cirrhosis and the differential diagnosis of AKI in cirrhosis to take those blinders off of us. Then we have to spend some time talking about hepatorenal syndrome, the pathophysiology, its diagnosis and treatment. And if you get nothing from me today, I will sleep very well if just everyone with AKI and cirrhosis does not have HRS. The presence of cirrhosis does not put HRS on your differential, and hopefully automatically. And so hopefully we can at least understand when it's appropriately used. And then we'll hopefully at the end put it all together to make a cogent diagnostic and therapeutic approach that all of us from the nephrology, hepatology, hospital medicine world can use so we can take care of these patients together using the same terminology. So just to look at some data, you know, AKI in patients with cirrhosis is rather common, which I'm sure anyone here would not argue with. Depending on the cohort used, up to 50% of patients with AKI, with cirrhosis will have AKI during that hospitalization. Obviously, depending on the techniques in which the data is taken, it can be a little hard to drill down in retrospective review of the etiology, but about a third to a half are hypovolemic AKI. About a third of those, depending on the study, can be acute tubular necrosis. And then, as we can see here, the variability of HRS, hepatorenal syndrome, can be quite broad. But I think part of that is due to changes of the definitions. And again, I really would say, I'll believe you if you tell me a patient has HRS, depending on what your workup's been. I think, again, it's thrown around a lot. So any data that just looks at HRS, yes, no, we have to take with a grain of salt, pardon the pun, as a nephrologist. Also, diagnosing AKI through standard KDIGO guidelines can be rather elusive. Sarcopenia can affect creatinine generation in the setting of cirrhosis, and hyperbilirubinemia, depending on your assay, can interfere with the proper detection of serum creatinine. The use of BUN can also have similar problems, as you can see here. The use of cystatin C can actually unmask renal dysfunction in cirrhosis. The caveat being, just like creatinine, it needs to be in a steady state. But as you can see from these receiver operator curves, the purple and yellow lines here are the epi-GFR equations using both cystatin C and creatinine very much outperform the use of serum creatinine alone. And this was using 24-hour creatinine clearance as a gold standard, I believe. Again, it should not come as a surprise to you that AKI in cirrhosis is very, very bad. If you have AKI in cirrhosis, your risk of dying is very high. And that, you know, again, at this study out of MGH, where I think this cohort study did a very good job of really teasing out, is this HRS, ATN, pre-renal azotemia? You can see it's about a third, and a third as far as the etiologies. And for the nephrologists in the room, I think we grumble about starting someone on dialysis based on their etiology. If they have HRS and they're a transplant candidate versus ATN, that may, depending on the nephrologist, change how we approach offering dialysis from a palliative care goals of care standpoint. But from this data, I would point out that the 90-day mortality of HRS versus ATN is about the same. And I think that is rather humbling to me, and just something to keep in mind as we take care of these patients. As we start, you know, we will more formally go into how do we actually make this diagnosis, but just eyeballing it, the higher your creatinine is, the more likely it's going to be HRS or ATN, with all the caveats that come with serum creatinine measurements. So creatinines less than 1.5 are more likely, based on this study, to be due to prerenal azotemia compared to other etiologies. So the differential diagnosis of AKI and cirrhosis. Again, everyone with AKI and cirrhosis does not have HRS. This review does a really good job of going through the different etiologies. And whenever I think of AKI, I start at the heart and move my way to the urethra, and following the flow of blood and filtrate. So the more common, the glomerular nephritides, prerenal azotemia, obviously HRS, ischemic ATN, we'll spend a lot of time talking about. And I think in general, most of us are familiar with this. I won't spend a lot of time talking about these things, these etiologies outside of this slide. And a few things to point out. Acetaminophen toxicity absolutely can still cause toxic ATN, just like it can cause necrosis in the liver. So in your Tylenol overdoses who have AKI, that can still be a cause. AIN from commonly prescribed medications in this population can also happen in cirrhosis. And then aside from traditional obstructive causes, midodrine, which hopefully at the end of this we will use less in HRS, can cause, although rare, urinary retention as well. So because I can't help myself, when should we suspect something outside of prerenal azotemia, ATN, HRS as an etiology? A really severe decline in renal function that's not otherwise explained, and also the presence of significant proteinuria or microscopic hematuria tells me that the lesion is more proximal, not proximal tubule, but in the glomerulus itself. So when we think about GNs in cirrhosis, we really think about the other diseases that can cause cirrhosis. Hepatitis B can cause a bunch of different types of glomerular nephritides, less common in the United States, however. And that can either be from a chronic viral infection leading to immune complex deposition, leading to things like secondary membranous nephropathy, MPGN, and even secondary IgA nephropathy. There's also data to suggest that you can have direct viral invasion of the podocytes themselves that can lead to things like FSGS or minimal change disease, which at their core are podocytopathies. The lesion of a podocytopathy would be hinted at by having a very nephrotic, i.e. large proteinuria phenotype. Hepatitis C is also a very common etiology of glomerular disease. And in fact, despite having normal renal function or normal urinalyses on autopsy studies, more than 40% of patients with hepatitis C will have evidence of immune complex deposition within the glomeruli. The most common manifestation of hepatitis C-related glomerular disease is cryoglobulinemia. However, secondary IgA, FSGS, and fibrillary GN have also been described. Why does hepatitis C cause cryoglobulinemia? We always think of the tropism of hepatitis C virus to hepatocytes. It also can affect our plasma and B cells. And so you can imagine a B cell or a plasma cell that is under the inflammatory milieu, maybe of being infected by a virus, can cause it to make abnormal protein. And what is cryoglobulinemia? That is the deposition of cryoglobulins in small blood vessels. This was a case that I saw in residency, the patient that presented with painful purpura on their leg. We biopsied them and it showed beautiful cryo plugs. This is the cryoglobulin actually causing a mechanical obstruction of our capillaries. And then beautifully under electron microscopy, this is a very linear sheet-like deposition of the cryoglobulins within the capillary itself. And secondary IgA nephropathy. If you go back to the wards and look at your patients who have cirrhosis, I bet a lot of them will have microscopic hematuria. And the presence of secondary IgA nephropathy is rather common in cirrhosis. And that is thought to be not due to abnormalities of Peyer's patches making galactose deficient IgA, but rather impairment of the clearance of IgA that is normally done in the enterohepatic circulation. Also, a rather controversial topic, but beautiful pictures, is the presence of kalemic nephropathy. Why is it controversial? Well, this is rather a chicken or the egg. If you have cirrhosis that's bad enough to turn your kidney green, your risk of having your milieu for AKI is rather large. So if it does exist, it has to be in the presence of severe hyperbilirubinemia. In studies, it seems to be bilirubins in the 20s. And again, is this just bile staining Tam-Hofstra protein, or is this actual bile causing obstruction of the tubules? And when you look at it on biopsy, you can see beautifully stained tubules with bile and even obstructive bilirubin crystals with inflammatory reaction around. So in the patients that we see, usually more of an obstructive jaundice presentation, have AKI and we can't really figure it out. I would say that in the absence of an obvious hemodynamic or toxic insult, I think I have seen this myself, and I luckily don't have any gray hair yet, so I haven't been a nephrologist for too long, and this I think does exist practically. The other thing to keep in mind is our patients with very tense ascites can cause renal vein congestion, interfering with renal perfusion. And while doing large volume paracentesis in cirrhosis in AKI can be controversial, there are data that suggest that doing large volume paracentesis can improve renal hemodynamics. This is in patients with tense ascites. And as you can see, after performing a large volume paracentesis, I believe in the study defined as greater than 3 liters, that does show some improved parameters of renal hemodynamics based on ultrasound. I would use this as a time to say, and the data here aren't great. It's all retrospective, looking at patients with HRS and seeing what happened to them before they came to the hospital. And it seems like the sweet spot is less than 3 liters. When patients have a paracentesis greater than 3 liters, your risk of developing bona fide HRS increases. Having said that, it's very uncomfortable to have more than 3 liters in your belly, and we all have those patients that need more than 3 liters removed. And what I always recommend is for every liter above 3 that's removed, I give 12.5 grams of 25% albumin back. Obviously, we are not robots, and we have to be mindful of this recommendation. If someone has intravascular volume overload, we can certainly worsen that by being too aggressive with our albumin repletion. So this is not a hard and fast rule, but if we're taking 10 liters out of someone's abdomen, we should probably give them something back. Now, as we move into HRS, the hemodynamics in cirrhosis keep us in a state of low effective circulating volume. So in order for the kidney to defend its proper perfusion pressure to maintain a proper GFR, it walks a razor's edge. Why is that? Due to the increased resistance within the hepatic vasculature, we have shear stress. That can lead to splanchnic vasodilation, which leads to vasodilatory milieu mediated by things like nitric oxide. That leads to a high sympathetic nervous system state, and also the activation of the RAS system. That leads to reduced renal blood flow due to renal vasoconstriction. In addition, due to things like high output heart failure, in order to defend a proper cardiac output, you have to increase your heart rate. That can lead to cirrhotic cardiomyopathy. And if you really are interested and you delve into cirrhotic cardiomyopathy, there are changes that the inflammatory milieu of cirrhosis and hyperbilirubinemia have on a lot of the ion channels that control heart rate, chronotropy, and ionotropy as well. And what's interesting is the liver and kidney talk to each other. This is from an older study in patients that were undergoing routine portography in the setting of portosystemic shunting. And what they did is by occluding the renal vein, we were able to demonstrate a rather rapid reduction in renal blood flow that was restored. So as the resistance within hepatic vasculature increases through mechanisms we don't quite understand, but rather rapidly, that in itself can lead to reduced renal blood flow. And again, our patients with cirrhosis walk a razor's edge in between adequate renal perfusion and prerenal azotemia. We already talked about the reduced effective circulating volume. High RAS state leads to high vascular tone within the kidney and renal vasoconstriction. not to mention the things that we do to our patients with cirrhosis. They need to take laxatives to stave off hepatic encephalopathy. A lot of them are on diuretic therapy to reduce the burden of their ascites. They undergo paracentesis frequently. Hypoalbuminemia can also lead to reduced effective circulating volume, and then the poor oral intake as well places these patients at very high risk of prerenal azotemia. But also state that there's renal vascular rarefication in cirrhosis. Why that is, we don't know. Now, this is from a rat kidney in the state of common bile duct dilation, so very different pathophysiology than the typical cirrhosis that we see. And why that is, we don't know. But we know from the heart failure literature that states of RAS activation can lead to chronic scarring within the kidney. We know that aldosterone, outside of it allowing us to excrete potassium and reabsorb sodium, is also a pro-inflammatory and pro-fibrotic hormone. It activates things like TGF-beta, et cetera. So I would guess that the physiology of cirrhosis and high sympathetic tone and high RAS activation likely leads to such prolonged renal vascular constriction that may lead to more chronic scarring and irreversible injury. Okay, now that we got all of that out of the way, hepatorenal syndrome, and I'll say it for the 5th time, not every patient with AKI and cirrhosis has HRS. So what causes this? Well, we already spoke about it a few slides ago. Cirrhosis causes splanchnic vasodilation. Why is that? The shear stress from the high resistance within the liver leads to cell injury. That leads to the release of damage-associated molecular patterns. Also, due to the changes in enteric blood flow, that can lead to bacterial translocation from the gut into the bloodstream and ascites, leading to the release of pathogen-associated molecular patterns. DAMPs and PAMPs can activate our innate immune system, leading to a pro-inflammatory milieu that can lead to things like vasodilation, again, further worsening our splanchnic vasodilation and shunting blood away from the blood flow from the vein into the splanchnic circulation. So aside of the vasodilation that shunts blood away from the kidney, we already talked about cirrhotic cardiomyopathy. And again, all of this worsens states of reduced effective circulating volume, triggering activation of RAS, leading to renal vasoconstriction to try and defend its GFR. As far as the kidney is concerned, HRS is just a very severe prerenal injury that is not improved with albumin. That's why we give albumin in the beginning of our workup. That's why the urine sodium is low in HRS. Again, why? Because as far as the kidney knows, all our beautiful organ knows is that it is not receiving enough flow. And the kidney deals with that by releasing renin, which activates and leading to the RAS cascade. So going back to this study. So HRS, again, is a state of profound prerenal azotemia that is not reversed by repleting the effective circulating volume. This was a study done in the 1970s where they did a renal angiogram in a patient with cirrhosis and oliguric AKI. And as you can see here, there's terrible renal blood flow. This was done post-mortem of the same kidney that showed restoration of that renal blood flow. What is this showing? The architecture of the blood vessels doesn't change. It's just severe renal vasoconstriction. And there have been studies where they have taken patients who had previously normal renal function, who developed HRS and died, and they transplanted those HRS kidneys into people without cirrhosis, and those kidneys did fine. So this is a potentially reversible injury. What's difficult, though, is the way you really need to reverse that is you need to fix the underlying pathophysiology, which is with a liver transplant. However, prolonged HRS likely leads to irreversible ischemic injury, the same way that prolonged prerenal azotemia can lead to ischemic ATN. The same thing can happen in HRS. So why is that important? Early recognition of HRS and reversal or treatment to improve renal blood flow is essential at preventing these patients from getting on dialysis, which I will show you that once you have cirrhosis and are on dialysis, your mortality is even worse than the data I already showed you. Why is HRS confusing? Well, the definitions have changed. Every generation of doctor in this room has been taught a different definition of HRS in medical school. And when we look at these things here, what stands out? Well, first of all, you need the proper hormonal milieu to support HRS. What does that mean? You need to have ascites, you will likely have hyponatremia, and you will maybe not be frankly hypotensive, but you should not be hypertensive based on everything we just talked about. The older definitions used a specific cutoff for creatinine. And as we showed at the beginning of the talk, due to sarcopenia, for a cirrhotic to get to a creatinine of 1.5, that may actually signify a really advanced reduction in GFR. So the most modern definitions of HRS use the KDIGO guidelines that we use today. And again, we give them albumin, typically at a dose of 1 mg per kg per day for 2 days to rule out that this is a reversible plain Jane prerenal azotemia. You should also be in the absence of other nephrotoxic insults. If your patient is in shock or had a GI bleed, it is not HRS. It's not. Okay. Sorry, I will. That was more for me than it was for you. One thing that I think will change, though, is this: the absence of overt proteinuria. Why is that? Because proteinuria, again, hints to us that there is a glomerular lesion. And typically that would say that there's another etiology to the renal dysfunction. However, as our population ages and as we see the etiology of cirrhosis shift from hepatitis C and alcohol to more things like steatohepatitis, the metabolic syndrome driving that disease will also, those patients will also likely have diabetic nephropathy. And there's no reason that you can't have pre-existing CKD with diabetic nephropathy and then develop HRS. And that is an area that our new definitions are deficient in. I would also state that the terminology HRS type 1 and type 2 has changed to be a little bit more direct. HRS AKI or HRS CKD. HRS AKI is exactly what we think about it. It meets the definitions of AKI in the setting of HRS physiology. That used to be called type 2, type 1. Type 2 HRS was more of a chronic process. And what is that? Well, that's what we're talking about. Someone who has cirrhotic physiology that is causing that slow renal vasoconstriction, likely leading to irreversible damage. We now call that HRS CKD. HRS AKD, or acute kidney disease, is the term we use for the purgatory between AKI and CKD. In my world, you need to have your new baseline for 3 months before we say that you still have AKI or you have met your new baseline at CKD. So practically, HRS AKD is not something we'd use day to day, but important to know. Just again, it's illustrative of the physiology. I won't go through all of this because it's not really worth our time to do study by study, but you can pick any line on this slide and it is terrible. Patients with HRS AKI have a very high mortality rate and they die. And we need to do better at treating them. And if we can, as we talked about, the sooner we can identify HRS AKI and start the process of reversing that underlying pathophysiology, the better our patients will do. The 15% of patients not listed, either with HRS, AKI, or ATN, only 15% were alive at 6 months without a liver transplant. Again, although it actually in this study here, although not statistically significant, just to drive home to our nephrology colleagues, ATN and HRS have very similar poor prognosis. And I think we really need to do our patients justice by being open with that, both with the patient, the families, and consulting services to the primary team about what the next 6 months will look like for a patient that cannot be listed for a transplant. Now, that's not to say, I'm not to make the judge that 6 months might be worth it to somebody. But if that 6 months keeps you in the hospital, in the ICU on CVVH, that math might be different for other people. And I'm not to say who it is or isn't, but I think it's important as for the oath that we take to make sure that before we make that decision, whenever possible, the patients know what we're getting them into. HRS reversal post-transplant. If you don't have HRS reversal after transplant, 60% of you will, 40% of you will die 1 year after transplant. So if you go into transplant with HRS and you don't recover your renal function, 40% survival. Having said that, about 3/4 of patients will have HRS reversal after transplant. Lower creatinine and lower duration of HRS pre-transplant obviously portend a more favorable prognosis. This data showing that the longer pre-transplant need for dialysis is associated with an increased risk of ESRD, non-HRS reversal. And as we can see here, about the longer you're on dialysis, the worse you will do. And that cutoff seems to be about 14 days. That's where the SLK, this study is what the SLK criteria for dual liver kidney transplant comes from. Dialysis need for at least 14 days pre-transplant. Not surprisingly, the need for renal replacement therapy after liver transplant is also associated with poor survival. 5-year survival for people needing dialysis after liver transplant is just under 40%. And again, not surprising, it's also associated with risk for ESRD. So what am I getting at? Again, we talked about, yes, if you need dialysis at the time of your liver transplant, your chances of dying is a lot higher than someone that doesn't need it. I don't think that surprises anybody here in this room. That's more or less common sense. But the worse your creatinine is pre-transplant, and the longer your AKI has been around pre-transplant, reduces your likelihood of reversal. And again, proper identification of these patients and proper treatment with not highly, but with effective therapies is the best chance that we can give them. What are we doing? All our therapies for HRS, whatever one you think of, midodrine and octreotide, norepinephrine, terlipressin, all that is doing is increasing MAP by vasoconstrictor therapy, trying to shunt blood away from the splanchnic circulation where it is pooled to increase renal blood flow. That is all we're doing. Having said that, these are Band-Aids. Without correcting the underlying pathophysiology, the underlying cirrhosis with a liver transplant, this process will continue to cycle through. Why is that? Because there is derangement of renal autoregulation in states of HRS, meaning you need a higher MAP to achieve the same amounts of renal blood flow than you would in non-HRS physiology. And this rightward shift looks the same for cerebral autoregulation in other disease states too. So why is that important? Well, what's interesting is if you pool all of the randomized controlled trials looking at treatments of HRS, so this is looking at midodrine and octreotide, terlipressin, norepinephrine, which we will get into with the last 30 minutes of this talk, we can see a nice correlation between increase in MAP and decrease in serum creatinine. So if we can increase the MAP by about 10, we can reduce the serum creatinine by about 1 milligram per deciliter. And that may be, obviously, again, there are issues with serum creatinine, but that's what we have right now. And we can imagine that if we can have a therapy that drops a creatinine by about 1 milligram per deciliter, aside from, significantly reducing someone's muscle mass with amputation, that is probably enough to pull them away from the ledge of dialysis. So this is where I think we can all do better. Midodrine and octreotide are no longer recommended in the treatment of HRS. It is not even mentioned in the most modern reviews of treatment of HRS, and I will show you the data as to why. This is from the New England Journal from 2023. There's no mention of midodrine and octreotide in their treatment algorithm. So when we are using midodrine and octreotide, we're no longer practicing standard of care. The Liver Disease Association and the American College of Gastroenterology no longer recommend it. AASLD states that terlipressin or norepinephrine are first line, and they really only recommend midodrine and octreotide if neither of them are available. ACG doesn't mention it in their guidelines at all. So why is that? So Just to take a pause, I think we all understand how midodrine and octreotide work, midodrine being an alpha agonist causing vasoconstriction, octreotide shifting splanchnic blood flow. Norepinephrine is a vasopressor that we're familiar with. Terlipressin is a prodrug analog of vasopressin that gets metabolized and leads to splanchnic vasoconstriction and improvement in renal blood flow. Why does terlipressin exist and not vasopressin? Because terlipressin does not need central access to be given. Theoretically, this drug can be given in a step-down unit or even the floor, depending on the nursing availability and comfort of the institution, and again, does not need central access. So looking into this, starting with terlipressin. So these are the two original randomized clinical controlled trials looking at terlipressin in the United States. As some of you may be aware, terlipressin has been widely available in Europe for some time. These were terlipressin versus placebo, which is unfortunate, but we have it versus other therapies coming. And in 020401, wonderful, catchy name. And in the reverse trial, they looked at terlipressin in patients with what was called HRS type 1 at the time. And while it did show initial improvement in creatinine, it was not sustained, and there's no difference in survival. What I would notice in the trial from 2008 had more, despite being randomly having a randomization, there are more patients in the terlipressin arm with the creatinine greater than 7. Right? That's a very bad AKI compared to the terlipressin arm, 6 versus 0. In the reverse trial, they tried to exclude patients with a creatinine greater than 7, but 3 patients in the terlipressin arm were discharged before they could have a confirmatory creatinine. So again, there's the water is muddied here. And also, I would say that the patient numbers were not that great. The confirmed trial that was recently published in 2021 had 300 patients. It had a mean creatinine of 3.5 in both arms, which again, I would still say is pretty far down the path for the patients that we are getting consulted on with AKI and cirrhosis. They excluded patients with creatinines greater than 7. They both had very sick liver patients based on their MELDs. What was nice with this trial is they wanted reversal of HRS, defined as 2 consecutive creatinines less than 1.5, and survival without renal replacement therapy at 10 days. So sustained HRS reversal, which I think is much more clinically relevant than a drug that can drop a creatinine for a couple of days. And we saw that. We saw that here. And I think we all could just feel in our bones, although I can show you, I can hit you over the head with more data. Doing dialysis in these patients is not great. And a drug that prevents us from having to dialyze someone with cirrhosis is important. However, death, about the same in both arms. However, death due to respiratory disorders was much higher in terlipressin. And we'll talk about that. And that is something we can't ignore. What's interesting when we pool all of these data, so these are all the RCTs in the United States, terlipressin versus placebo, we found that the HRS reversal was sustained at 60 days, 90 days, not so much. But in patients that received liver transplant, the definitive treatment for HRS AKI, that was sustained at 90 days, which isn't necessarily surprising. But again, highlights the importance that any therapy for HRS AKI short of liver transplant is just a Band-Aid. It will come back. Again, when we look at patients with that got liver transplants compared to those that didn't, patients who received terlipressin were able to be kept off of dialysis. One thing that's really important, though, is the MELD score takes into account a creatinine. And some may say that if I give you a drug that doesn't really change your survival, but reduces your creatinine and I lower your MELD score, I'm going to knock you down on the liver transplant list, and I could be doing you harm. That didn't seem to be the case in these trials. So that's 100, 200, it's about 600 patients that this was done, half of those being patients that received terlipressin. So what about other therapies? I just showed you terlipressin versus placebo, but let's compare that to things that we use. This is midodrine and octreotide versus terlipressin. That was a complete recovery of 70% versus 28%. And I think if any of us in our room had a patient, a loved one in the hospital with HRS-AKI, I know what therapy I wouldn't want them to be getting. But practically, we don't have terlipressin on formulary, and a lot of places don't. What about norepinephrine? This is, again, small numbers, but terlipressin versus norepinephrine showed that it was about equivalent in response rate. Again, not great, about 40%. Again, this disease is very bad, and without transplant, there is no definitive treatment. So these are Band-Aids. Having said that, it seems to be about equivalent to norepinephrine. Still pretty high creatinines in the 3s. This patient population, the MELDs were a lot lower compared to the terlipressin versus placebo trials. Another study, similar demographics, a little bit better response rate, but again, hints that terlipressin seems to at least be equivalent to norepinephrine. It's interesting that perhaps continuous infusion may be superior to norepinephrine. The thought is if you have more stable pharmacodynamics with a continuous infusion rather than Q4 dosing, that may improve having a constant state of vasoconstriction, improving renal blood flow. In this patient population, though, less sick with regards to their AKI. And although most of us in this room don't have experience using the drug terlipressin, it has been well studied. The size of the circle represents the number of patients that have been done in all RCTs looking at HRS. The black lines are looking at the comparative therapies. So we talked a lot about terlipressin versus albumin. We talked a little bit about terlipressin versus norepinephrine. And there's only one, the study that I showed you, looking at terlipressin versus our most commonly used ineffective therapy of midodrine versus octreotide. I promise you, I'm not going through every single one of these studies. I didn't have it in me to read all of them, but glancing a good chunk of them I showed you. You can take my word for it, though not all of you know me. Those are very illustrative trials looking at the rest of these. And when we compare them, the serious adverse events is a big reason why people shy away from using terlipressin. So let's look at that. In the confirmed trial, that was the most recent, largest RCT of terlipressin versus placebo in the United States. We talked about that there were increased rates of acute respiratory failure. I don't know that they split it between acute and regular respiratory failure. Take that for what you want. But also death. In the patients that died in the terlipressin arm, a lot of them died from respiratory failure. Now, that is something that we cannot ignore. Why do they think that is? Well, they think that based on where the receptors that terlipressin acts on, that may cause reduced pulmonary vascular resistance and increase, so you can increase the cardiac output to the pulmonary vasculature, leading to pulmonary edema, but that is just that isn't proven. At the end, in a few slides, I'll also show that the confirmed trial was done in a time of very heavy albumin repletion and cirrhosis. In fact, in the same issue of the New England Journal, they had the confirmed trial and another study looking at target serum albumin cirrhosis, which I'll show you later. So it could just be that these patients were aggressively volume repleted as well. However, there are things that we can do to properly select the patient population to mitigate these adverse effects. In patients with ACLF grade 3, they were most likely to have acute respiratory failure when given terlipressin compared to placebo. That's not to say there was no respiratory failure in grades 1 and 2, but as we can see here, death from respiratory failure was much more common with more advanced liver failure. Also, HRS was terlipressin was ineffective at HRS reversal in patients with more advanced liver failure, and also less effective at higher creatinines. The severe, I believe, was creatinine of 3.5 or so. So we can already see that there are some things that we can do to improve the patient population to, one, identify patients that have the best shot of having HRS reversal and who are at lower risk of developing the most common side effect being respiratory failure. Also, another study looking at continuous infusion seems to have reduced adverse events, 35 versus 62%. Due to this, that might also be that in the continuous infusion dosing, you have a lower total daily dose of terlipressin as well. The VA has terlipressin on its formulary. And for those that, if the VA is going to approve a drug, an expensive drug, on their formulary, it needs to make sense to them more so than it would at other medical centers. And the VA did a very good job looking at the data I just showed you to really have very strict, but I think appropriate exclusion criteria. Patients with grade 3 liver failure are unlikely to benefit, meaning they're unlikely to have HRS reversal and are more likely to have respiratory failure due to this medication. Serum creatinines greater than 5 are also excluded because the idea is that the cat is out of the bag. But with the data that I already showed you, you could maybe even argue that you could bring that creatinine down closer to 3.5. Obviously, pre-existing hypoxia as well. So I think there are ways that we can mitigate the risk profile of this medication. And it also say that this drug is there's gatekeepers to this drug at the VA. Hepatologists or nephrologists, ICU doctors are the ones that need to make the decision. And I think that's appropriate given all of the complexity and nuance to this medication that we talked about. So the treatment summary. I think it's safe to say that norepinephrine is superior to midodrine and octreotide. And in the GI societies, it's not in their guidelines. Terlipressin is at least equivalent to norepinephrine. And the benefit of that is you don't need ICU or central access. And some people will say, well, if we're kind of clever about it and get a PICC line beforehand, maybe we can avoid a central line if we kind of see the writing on the wall. But I would also say a lot of my patients that we're seeing are probably not the best PICC line candidates as well. I do think there's good data to say that terlipressin reduces the need for dialysis in this patient population, which we already spent some time discussing why dialysis and cirrhosis is bad. And we can mitigate the adverse events with proper patient selection. So putting that all together, so as we talked about, when you have a patient that you're suspecting HRS AKI, the use of an albumin challenge is helpful because it helps you distinguish between plain Jane, reversible, pre-renal AKI, or HRS, which by definition is not improved with giving a volume challenge. Urine microscopy is also really helpful because the presence of a lot of muddy brown granular casts is more likely to be with ATN. A few granular casts can be seen in any type of renal injury. But if you have sheets of muddy brown casts, that is most likely ATN, not HRS. Although, as we said, the mortality may not be different. Our ATN is supportive care, HRS has treatment. But other things to just point out, what's beautiful about spinning urine in HRS is if they have hyperbilirubinemia, it can help you, it acts as a stain for you. And here we have renal tubular epithelial cells, proximal tubule cells that fall off, get stuck in uromodulin and degrade into muddy brown casts. This here is actually seen very early in the case of ATN. We can see bilirubin crystals. And if you spin enough urine in cirrhotics, you will see these oil droplets. These are leucine crystals. Sometimes they get crushed on the microscope slide and polarize. They are found in patients with cirrhosis. Why that is, we don't know. They don't seem to have any clinical importance, but they're there. And if you look, you'll find them. So what do? We talked about, we try our, we remove offending agents, stop diuretics, try to reduce the amount of laxatives that we use, taking rid of the typical nephrotoxic medications that unfortunately seems to sometimes be the only recommendation we can give people. And then we try volume expansion. If they get better, we're done, just like any other AKI. If they are unresponsive, spinning the urine can be helpful. This is ATN. This is not ATN. This depends, right? You can have some granular casts. And then once we go down this, so once we have someone that does not have a high cast burden, has been unresponsive to volume repletion without an obvious etiology, Now we start going down our HRS treatment protocol. Again, lower blood pressures, mild to true hyponatremia, and not hypertensive physiology all make sense for someone to have a hepatorenal syndrome milieu. And then that's when we start vasoconstrictor therapy, meaning terlipressin and norepinephrine. So anyone who's been on service while I've been on doing consults has probably seen my dot phrase over and over again, now starting to recommend against using midodrine and octreotide. Now, it's true that raising the MAP by 10 millimeters of mercury is likely the most beneficial thing that we can do. And if we have absolutely nothing, I think it's better than nothing. But as I've shown you, the use of midodrine and octreotide is a really inferior therapy. So what does that look like? We don't have terlipressin here, so talking about how it's dosed is not a good use of our time. But again, when we use norepinephrine, these patients aren't frankly hypotensive like we normally would require an ICU admission to use norepinephrine. Our goal is to put them on a fixed dose to increase their MAP by 10 points. So that may be bringing a MAP of 80 to 90. And then we sit and we wait for 3 days and we reassess. If the creatinine is improving at 3 days but not back to normal, keep them on it and continue to monitor. If they haven't shown any improvement at 3 days or gotten worse, then they're unlikely to get better. And that is really made up. There's no data to support that, but that is borrowing from how terlipressin is used. And obviously, we need to tailor this therapy to each patient. You know, people with tachyarrhythmias may not be able to use norepinephrine, and in that case, midodrine and octreotide is not great, but better than nothing. 14 days tends to be the trial period. After 14 days, there's no, from our clinical trials, these patients won't get better afterwards. And again, keeping in mind, prerenal azotemia and HRS lie in a spectrum. If you have HRS for a long period of time, that can lead to irreversible kidney damage. So identification of HRS early, proper treatment early, can help prevent the progression to an irreversible injury. Just some things coming down the pipeline, although not available. Urinary NGAL, that's a tubular injury marker. So if the tubules are damaged in ATN, your urinary NGAL will get leaked into the urine and be high. HRS, like prerenal azotemia, is really a hemodynamic injury. So when it's available, urinary NGAL can be another data point to help us differentiate between these two etiologies. And also urinary NGAL was useful in predicting responders to non-responders with regards to terlipressin. So although it's not available to us now, it will probably be something that will be available in all of our careers and another piece of data to help guide our management. And this is the albumin that I was talking about. In the same issue of the New England Journal, it really asks the question, is keeping a patient who has with cirrhosis, who has hypoalbuminemia to a serum albumin greater than 3 beneficial, from restoring effective circulating volume, from preventing infections, et cetera. And so what we can see is the patients who receive in the albumin arm certainly received a lot more albumin and certainly had an improvement in their albumin. But there's no change in infection, AKI, or death. There was, unsurprisingly, an increase in pulmonary edema in the intervention arm. And so you can imagine in this therapeutic milieu, where people are getting a lot more albumin than they need, who are getting a drug that can increase your risk of respiratory failure, this is another way to mitigate that risk if we are ever able to use terlipressin. Then we can also, of course, use POCUS. Why not, right? It's 2024. And what they really looked at in this study is saying, right, we say a mg per kg of albumin for 2 days. Why is that? Well, a mg per kg for 2 days for someone who's 400 pounds may not be enough to restore effective circulating volume compared to somebody who is 90 pounds, that may be more than enough. And it really looked at using POCUS to look at the IVC diameter and collapsibility to get an idea of the effective circulating volume. However, as anyone familiar with the POCUS literature knows, IVC diameter and collapsibility is not a perfect or reliable measure. But it's an interesting proof of concept. And just because I'm running out of time, I won't go through all of this directly, but you can imagine based on cutoffs on IVC diameter and pulsatility, they're able to say, oh, this patient still seems to have reduced effective circulating volume, give them more albumin, or this patient actually has his volume expanded, maybe give them diuretics, or there could be signs of intra-abdominal hypertension, give them paracentesis. And when we looked at that, it's not great, but I think they were able, I think the takeaway for me here, right? A third got better, a third got worse, a third stayed the same. That's not a great intervention. But I think it did identify patients that despite getting the typical albumin infusion, were still volume depleted. And by giving them more albumin, they did get better. So again, this just goes to show we are not robots, and hopefully that is why ChatGPT will not replace us until my student loans are paid off. And again, we can't just blindly follow anything that I told you today. We have to think. And this just shows that, because what are we doing with our therapies? Albumin, we are trying to expand effective circulating volume. And when we treat HRS, we have to think of, why am I recommending this therapy? What is my goal? My goal is to increase the MAP by 10. If I put them on norepinephrine and their MAP's not increased by 10 and they're not doing better, increase their MAP by 10. So what am I saying? Not everybody with AKI and cirrhosis has HRS. All of our cirrhotic patients are at very high risk of prerenal azotemia. And the longer we are in HRS, the more likely we are to have irreversible permanent kidney damage. We should stay away from therapies that have poor evidence and don't seem to get better, that don't seem to fit in our current guidelines. I think anyone in this room would not want their mother to get midodrine and octreotide if they were to have HRS AKI. Yes, that means that we are going to have to bother the ICU more, and that's just how we have to take care of our patients. And we can't use terlipressin, but terlipressin may not be better than norepinephrine, but it's at least equivalent. So we should use norepinephrine to treat HRS AKI and be careful with albumin. And that's all I have. Thank you very much.